I would like to take the opportunity to you, Herbert Down, from General Assembly, representative of Australia, to present an update from the Australian journey with the SNOMED CT.
Excellent. I've had a few technology fails in my time working at the Australian Digital Health Agency. You would think at this stage I'd have my act together. Thank you very much, General Assembly members, for inviting me to share with you some of the things that are happening in Australia at the moment with regard to interoperability, digital health standards generally, and how standardized clinical terminology fits in. I have the great pleasure of leading this work on behalf of the Digital Health Agency, and it's afforded me the opportunity to be here. It's really quite wonderful to be back in London. It's kind of a second home for me. It's close to Ireland, but it's not quite Ireland. And I have a lot of fond memories from many years of visiting here. One of the less fond memories I have, however, in 2017, round about late September, October, my brother came down with a very severe musculoskeletal disorder. He was rendered almost immobile, and over a period of 8 weeks, he was passed from one GP to another in a series of what I can only say were major bungles. He was prescribed wildly inappropriate medication, and after a period of time at Chelsea and Westminster Hospital, he was finally diagnosed and an appropriate treatment plan designated. I'll tell you later on what exactly happened to him. I've spent a lot of time focusing on the conversation we had one Saturday afternoon when he asked me, would his doctors, and he's got some different complaints, so he's got a few of them, would they all know that he'd been in hospital and that he'd had this new diagnosis, a new plan put in place? I was pretty embarrassed to say that no, actually, what you've got to do is buy yourself a really good Filofax or ring binder and take a copy of every report, every pathology result, and every imaging report that you get, and bring that with you when you visit each clinician. You would think that in 2017, there would be a slightly cleverer solution available. Over the last couple of months, working really heavily in this interoperability space, I've gone beyond that particular conversation and realized that interoperability would have actually had him treated and sorted out much earlier on, had there been a really good system available. So, what are we trying to do in Australia? Before I move on through the talk, I just thought I'd share with you what we do at the beginning of every meeting. One of the things that interoperability will hopefully do is equal the playing field in Australia. And right now, Aboriginal Torres Strait Islander people suffer great inequity when it comes to access to healthcare and healthcare outcomes generally. So if I was in Australia, I would be paying my respects to the elders past, present, and emerging, and I would be acknowledging their connection to land, sea, and culture. I'm from a little place in Sydney called Woolloomooloo, and that's translated as the Bay of Plenty, and it certainly is a very beautiful place to live. So, I don't know how much you know about Australian healthcare, but it's pretty complex. For a small population of just 24 million, we've got a myriad of funders involved. We've got 8 states and territories. We've got a Commonwealth. We've got a universal access scheme that's actually relying 50% on private healthcare. And then we've got a population that's spread across an area about the same as Ireland to Moscow, give or take. Across that area, we've got metropolitan areas which have really highly dense tertiary and quaternary facilities. And then we've got much more remote locations which struggle to get a doctor to visit more than once a week. So things are not quite equal. And despite investment in satellites and various different types of ways of receiving internet connections, we still don't have stable connections in an awful lot of those places. For the first time ever, the 8 states and territories and the Commonwealth have all agreed that they want to work together on this particular area. COVID has perversely provided us with a consumer imperative to drive forward. For the first time ever, consumers saw what having clinical information, their own personal clinical information at hand, could help them do. And at various times during the lockdowns, they were able to access their pathology results within 24 hours on their My Health record, which is the universal health record for Australians, and then make decisions based on the local guidelines about what they could or couldn't do, depending on their infective status or those that were close to them. We need to capitalize on that consumer knowledge and imperative because it will be lost pretty quickly. I'm very interested in what happens to SNOMED and SNOMED International because within the plan, we've pinned all of our hopes on SNOMED being the standardized clinical terminology that's used in Australia. And right now we're pretty successful. We don't have any native implementations yet. We're waiting on that particular gold medal effort, but it is broadly used and accepted across the country. That fits into the very broad area of standards, which is essentially the secret to all of interoperability. And then within that, hopefully, we'll get to that place where we've got the safe, secure, and seamless sharing of consumer health information. I haven't been brave enough to ask just yet what either consumers or clinicians expect from that health sharing piece. Certainly over the next 5 years horizon, that's going to change quite dramatically, not least of which is because it is very much a change in clinical practice for GPs in particular. Australia is not the healthiest place on the planet. We've got a few health issues of our own. Approximately half of the population have a chronic condition. 3 out of 5 people over 65 have more than one chronic condition. And they take 2 or more medicines every day. So it's a fairly complex health situation for quite a small population. One of the things that always sticks out in my mind, because I'm a pharmacist, is that every year about 220,000 people get admitted to accident and emergency for medication misadventure. In my mind, this is the low-hanging fruit that we need to go after in the next 2 to 3 years to prove that the investment into interoperability is actually well worth it. At the end of the day, we're asking software vendors and health service managers to commit themselves to very large investments over the next few years to bring their systems in line with the rest of the country, without a very clear articulation of what the immediate and medium-term benefits are likely to be. This is where we need to be. If we could get rid of half of those, we would be removing a huge amount of morbidity and some mortality from the system, freeing up an awful lot of cash to invest hopefully elsewhere. The benefits to Australians themselves are a little bit easier to articulate, thankfully. And if we can get to even half of these at the end of the 5 years, then we'd certainly be in a terrific place. My personal agenda sits squarely in unwarranted clinical variation. I could never understand why, for no particular reason other than individual clinician preference, why clinical treatments vary or deviate from guidelines. Sucked up into a national repository, we'd be able to get really detailed access to those deviations, go in, tackle them directly at the point of care, and hopefully raise the bar across the country. That's a bit of a mind map of everybody that has skin in the game in Australia. It's not hard at all. You'll know that consumers do feature, they're not at the center. The funders play a massive role in deciding what clinical information systems look like, because many of them are developed as invoicing or administrative tools. And even at the moment, one of my teams is working on a business to government gateway with its primary focus being administrative data, not the consumer, not the clinical. We are, however, going to be successful in making sure that they use both SNOMED and all of the other standards that we have available, though that's not their preference. We're not short of willing collaborators. There's plenty of people who want to jump on board, but what we have been lacking is the central coordinated plan to make sure that we can get where we want to be. That's hopefully going to be changed in the next couple of weeks. 7 out of the 8 states and territories have given their approval. We're waiting on 1 to come through. I'm giving them another week's grace. They've just come out of caretaker after an election, so they're entitled to a little bit of rest. But after that, we'll be banging on the telephone line to make sure that it comes through. From there, we've done a little bit of work to figure out what exactly clinicians and consumers think about digital health, whether they actually know what it is at all, whether they want it, and what we can do to help them get there. Interestingly, consumers want really easy to use booking systems that link up their care teams. They also want really easy payment systems at the end. I think the analogy is the car park. In hospitals right now, most complaints received are about the car park. Some research in Australia has demonstrated that if you can improve people's car park experience, their perception of the care that they receive is actually better. It would seem like a no-brainer to me to tackle this straight away. Healthcare providers themselves are a little bit reticent, and they're a little bit unsure of what's ahead. For the first time ever, the doors will be thrown open on the secrets they hold in their records about patients. This is not to be underestimated, and I think many people still do. And the resistance that will come from this sector over the next couple of years will be pretty strong. The governments in federal areas obviously want to use population level data to improve the services that they provide, but they're also interested in this clinical variation because right now it's costing a small fortune, particularly in the area of pathology and unnecessary tests. How ready is Australia for digital transformation? Not ready at all. We still rely on the fax 30% of the time to move consumer health information around. It's terrifying. When I left pharmacy about 10 years ago, we still had dot matrix printers in the dispensary, I kid you not. I'm a dab hand though at getting them working again. The agency has a mandate within its rule, the public governance and performance rule, to lead interoperability, to lead standards. But when you look through our mission, you look through our corporate plan, you'll see that interoperability is actually woven throughout our work. Every aspect of what we do is about driving it forward. However, we don't have a mandate, we're not a regulator, we can't force anybody to do anything. And we have 9 different bosses, the 8 states and territories and the Commonwealth. It can be a little bit tricky to get things done. All around the stakeholders that we work with, we also have to work with them as partners. We can't tell them exactly what to do. Our conformance assessment scheme is developed in association with them. And ultimately, without that partnership model, we won't succeed at all. Oops, I should have advanced that slide, I beg your pardon. We want to make sure that the consumer is at the center of everything that we do. And to that end, following on from feedback during the last phase of COVID, we developed an app that will now give access on a mobile device really easily to all consumers and that universal health record that I mentioned. For the moment, it's read only, but just recently we came to an agreement with general practitioners and the Pathology College to allow access to immediate results for HB1C, INR, and a couple of respiratory tests. This can put the power into the consumer's hand to make decisions about their warfarin or other anticoagulant dosing, and it will hopefully drive control of diabetes and longer-term health outcomes into those people who suffer. This is the tip of the iceberg, and if we can get that clinical imperative moving, then we can show that it's worthwhile releasing other types of pathology results at the same time. Again, resistance is quite strong from the fee-for-service model for primary care that we have, but we need to keep driving forward. We're going to continue leading the implementation of the plan once it's released. And to that end, we've got a couple of key projects underway that will underpin it. The app, a digital health standards catalogue, and the national infrastructure modernisation, which I'll show you in just a moment. We're not starting from scratch by any manner of means. Over the last 10 years, we've actually put together a pretty reasonable catalogue of products and services that will support interoperability. However, some of it is creaking a little bit like a 1970s train and needs some severe investment to get it shipshape for contemporary use. We've managed to join up one particular part of the health system, and that's prescribing and dispensing. Electronic prescribing came out of an intense piece of work at the beginning of COVID, built, granted, on 10 years worth of work on health identifiers and standardized terminology. But now, approximately 55 million electronic prescriptions have been written or dispensed in about 13 months. It's a drop in the ocean in terms of the total number of prescriptions, and we still have some practice change to go through with pharmacists who insist on printing paper prescriptions off digital tokens. But I do feel that we'll get there. So, digging into standards. One of the first tasks I had when I took over this particular role was to rebuild the relationships with the standards development organizations in Australia. After a fallow period of 5 or 6 years, those relationships had degenerated quite significantly, and there was a fair bit of mistrust on both sides. I'm happy to say that we're now on really strong footing with HL7 and with Standards Australia, who are the ISO organization in Australia. We started out by developing a really simple set of principles that we wanted the community to get behind. We've moved significantly on from here, but at the time it was a conversation starter and it was reason to be in a room to have a constructive and helpful conversation, and they were part and parcel of driving this particular piece. This is going to sit on the front of our catalogue. At the middle of last year, we signed an agreement with the CSIRO, and Kate, I'm sure, is familiar to most of you in this room and sits on the member forum. She's leading that work at CSIRO. They've taken on the NCTS and will have responsibility over the coming years to, again, modernizing that piece, bringing the software up to date and taking AMT, the Australian Medicines terminology, to the next level. They are SMEs in this particular area, and I think this agreement is an acknowledgement of that. The agency retains responsibility for governance and the General Assembly here and sets the strategic direction, but it's the CSIRO that will lead the work itself. To date, it's proven to be quite a fruitful arrangement, and we're looking forward to some really terrific goals being achieved. One of the most exciting pieces that we've managed to deliver are the FHIR training program. Up until now, we've sent people to the US to complete their training, and invariably they leave within weeks of returning because of their ability to earn some very serious cash elsewhere. Localizing materials means that we've got complete control over the number of places that are available. And while we don't quite understand how many spots we actually need over the coming 5 years to achieve this interoperability plan, we're pretty sure we're nowhere close to having those humans ready to go. The agency is sponsoring 370 spots in total available by expression of interest to anybody in the country. And in phase 2 of this particular project, we'll be getting as far as a certified practitioner level, of which we'll need quite a few. We'll also have train the trainer courses, which will allow obviously the agency itself to benefit and provide its own in-house training, but it'll also provide a pipeline ongoing to make sure that we've got the expertise available to replace those that decide to step away. We also took the opportunity to develop a couple of more generalized courses so that people like me could actually understand what FHIR was about, how useful it could be, and why I should be thinking about it on a regular basis when it comes to developing policies and procurement documentation. The piece that I'm proudest of out of all of this is the Digital Health Standards Catalogue. It started out as a very simple, straightforward idea, and it's actually going to be, I think, the secret to creating an Australian standard. So that is, anything that goes in the catalogue will be the preferred standard where there are multiple available. And it'll take away the sort of guesswork that software developers tell us they have to do when they're trying to decide which way to go with a particular standard. Like I mentioned, the plan, the interoperability plan, has pinned its hopes on SNOMED as the standardized clinical terminology. DICOM, LOINC are also in there and won't be going anywhere for 5 years. And interestingly, it's the first time that the Commonwealth government has stepped into this space and actually said, this is the way that we want to go ourselves. Right now, we're in the process of negotiating some IP agreements to fill the catalogue. I'm adamant that it will be a one-stop shop. There will be no going behind that wall and then having to click away from the website. If we can't get it in there, then we're doing something wrong. So far, the negotiations are proving fruitful, but very expensive. Let's see how sustainable it will be over time. The catalogue will be accompanied by a community platform where we'll bring developers initially. Once the developers are up and running, I'd like to bring students and other interested parties to come along. I'd like to see a microeconomy created so that developers from all across Australia can get involved in standards work for short periods of time in between other projects, so that we get this ongoing pipeline of work through. Our agreements with the likes of Standards Australia and HL7 will hopefully allow them to develop stronger corporate structures within their health practices to make sure they can keep pace with the development that we anticipate will be required over the next 5 years. States and territories have recently signed up to developing health information exchanges, one per each state. I'm not entirely sure how that's all going to work, but I know for certain they need to be developing to FHIR, and they need common implementation guides, and we need to step in and make sure that that happens. I have a nightmare that occurs probably once every 2 weeks, where in 5 years' time, we've got 8 beautiful HIEs and none of them talk to each other at all. Just to give you a little idea of the app itself, we've done a huge amount of user interface testing. We've had lots of UX people involved in this one. It's probably the first time ever, I would say, the agency has had so much involvement from designers of various different types, and it's looking good. It was launched 4 weeks ago, and we've already surpassed the total number of downloads that we wanted, and it was the #2 health app within its second week in Australia. I'll tell you over drinks sometimes some of the nightmares that this one has caused in its pre-launch phase. Having that tool in consumers' hands, I feel, is the first step towards helping them understand the power that they could have. I'd like to see them voting with their feet when their clinicians tell them that they do not upload to My Health Record. I want to see them when they make their appointment asking, are you connected? If not, why not? Will you get connected? Then I'm going across the road. Aged care is almost a greenfield site completely. We're working with that sector, not just to embed standards, but to actually create a minimum operating position so that they can buy correctly from the get-go and not end up in a, similar situation set to the secondary care situation, which is great software products that work really well locally, but don't talk to anything or anybody, and certainly are not built entirely to standards, Australian standards at least. Okay, what's different this time? I'm new to the scene, so I'm still enthusiastic. I'm still positive and optimistic. Many of the people I work with have done this a couple of times over, and they've seen the chaos that's created when it does fall over. I've learned and I've listened. And while I can't guarantee we'll be successful, I think we are in a very different place. Not just because of that clinical imperative that COVID created, the raised consumer awareness. I think the imperative that's been handed to the agency in the last 2 years and the plan that's nationally agreed itself are all really, really important parts of the puzzle that we're missing before. If we can get the standards community really up and running, confident, pumping the work through and seeing that work adopted and used, then we're really on the winning streak. Just need to source the funding for the community platform and I'm sweet. I don't think the 50,000 that they've given me so far is quite going to cut it. Equity of access, unwarranted clinical variation, giving consumers the information they need, when they need it, where they need it, to make informed choices and decisions are all gold standard for modern healthcare. It's technically feasible to be interoperable, right? It's not all that hard, a little bit expensive, bit tedious, but not too difficult. So why hasn't it been done more successfully in more places? The human problem. The change in adoption piece is very, very complicated. People's incomes are directly tied to the models of care that they currently have. And the new models of care that interoperability will support are a little bit scary, and they don't quite have the kind of control that they'd like to have. We've got to help them through. We've got to help them see this shared vision, and that long term, it will be better for not just consumers, but for themselves. I know that when I was a pharmacist, if I had the kind of information that pharmacists do today on a Saturday afternoon, I'd be a lot more confident giving out the emergency supplies to the tourist who really, really does need them, but can't get access to a GP on a Saturday because, well, who works on a Saturday afternoon? Now, I'm required to give a shout out to MedInfo 2023. For those of you who aren't yet considering attending, this will be the digital health event for 23. It's happening in Sydney. A whole bunch of us will be speaking, and the lineup is really impressive. The dates, 8 to 12 July. It'll be a little bit chilly, no need to pack your thermals, but I'd definitely bring a sweater and a heavy jacket. If you'd like to know more, those are my contact details. The plan will be approved in the next 2 weeks. And once it is, I'd be happy to share a draft with anybody who is interested. It's got 44 actions. You'll notice that the agency is the lead for 40 of the 44. I did not lead development. I just have to deliver it now. It'll be an exciting time. And SNOMED is really the cornerstone that sits at the very bottom of the foundations that it's all pinned on. And that's all that I've got for you. I'd happily take questions if I've got time.
Thank you very much, Herbert, for this presentation. Oh, there's a question from Diane.
Thank you for that. I actually have two questions, and one I might have zoned out on, so my apologies up front. On the slide with the dosage errors, you called it medical misfortunes or pharmacological misfortunes. Yep. Is that on the prescribing side or the patient side or both?
Both.
Okay. And then my second question is, you had the My Health app, mm-hmm. And does that have any link outs to any consumer or patient kind of plain language information about their condition or treatment?
Not so far. Okay. That is the plan. We'd ideally like to make it at the front door to healthcare in Australia. But right now it's an optimized read-only version of the My Health record that we've had for quite a few years. The interface is much more consumer friendly than My Health record is itself. We're still reliant on the fact that it's a document repository, essentially, a nicely organized one, but a document repository all the same. Modernization would take us towards a more atomic data-based system, where we would then be able to render various different dashboards and so on, tailored to an individual's conditions. But yeah, it's in the pipeline.
Thank you again. Very good. So there's no more questions. So I think there's another one. Yeah, come on, please.
Yeah, talking this way and looking that way. Okay, thank you, Herbert. You mentioned the interoperability challenge is a human problem, and you mentioned that you have identified the opinion leaders. So what was your strategy for different groups of people where you need those opinion leaders, and how did you go about that?
For this particular plan?
Yeah.
It's pretty complicated. So the loudest voices were, without doubt, the medical software industry. And we have a checkered history with the representative body. And even now, they would say that we didn't consult enough with them. However, we have a long record of very intense consultation with them. Developing the plan itself was hard because never before have the states and territories been actually interested in having the conversation. they had their own stuff to worry about. The Commonwealth holds the purse strings to some of what they do. So when they tugged on them just a little bit, suddenly the states and territories started paying attention. Once they were on board, the software industry had to start paying attention themselves, because suddenly their customers were actually asking for the likes of FHIR, SNOMED, talking about interoperability and what that all meant. So it was chicken and egg, and I'm just not sure at different times which was coming first. The plan's been finished 15 months, but hasn't yet been approved. So it's all been a really difficult, delicate negotiation piece. There are no secrets. Resilience, going back time and again, holding strong, and trying to reflect as many of the concerns as they had within the document itself. There were some things that we just had to say, no, I'm sorry, you're not going to win on that one. This is the best practice, and that's the way we're going to go forward. Let me think of an example. Security requirements. We've got a conformance profile that's just been released, an assessment scheme that we would have liked to start already. However, there is a cost imperative now on imposition on software developers to actually show that they've done their penetration testing and other types of resilience stuff, and they don't like that. So we've had to pause for a little while, let them get used to the idea, and we'll go again in probably the third quarter of this year, and hopefully have assessments starting by the end of the year. Not easy.
Great. Well, thank you again. Is there anything more or more questions? There's one. Yeah. Okay.
Hi, my name is Aaron. So just a question in terms of the survey itself. So let's say once the app has been launched, how many times has the server been down? For example, if the patient goes to a pharmacy, let's say, here's my medication history, and then this app is not working. So I'm just being curious in terms of server downtime more than anything.
Oh, I see what you mean. Yeah. Funnily enough, we also released a new generation of API gateway this year, and that's caused lots of headaches. However, the redundancies built in means that downtime is actually quite minimal, a couple of hours at the very most. The app itself has been tested to 12,000 concurrent accessions. So we're pretty certain that's not going to cause any downtime itself. The biggest problem actually is in document uploads. And some of the APIs that handle that go down more easily than we'd like. And the knock-on effect of missing information actually starts becoming a real problem. And I think personally, that's where clinically we're going to have an issue very, very soon en masse. There's been a series of Fridays where we had some downtimes. The token for the prescriptions doesn't sit in the app just yet. So that infrastructure is actually private. It's not public. So to date, I don't believe we've actually had any downtime problems with the tokens. There have been some other issues, but not downtime. I guess the key part of it, though, is you can join up bits of the system, and eventually, if you join up enough bits of the system, the whole system should be together. And that's kind of the model that we'll be working towards, but with a bit more common pieces. So not starting from scratch every time, but more common pieces. The e-referral is next, and that's going to be pretty complicated from what I've seen so far. But I don't understand why it needs to be, because the information is almost the same as a discharge summary, for example. It's just in reverse. You ask the questions instead of providing the answers. The architects don't like me when I say things like that, though.
Okay.
Thank you all.
Thank you very much. Another applause.